Hey friends, I'm starting. So I'm Dr. Ajay Yadav. So what we are going to discuss today, as you know, is the very important topics, and these topics I have tried to make based on the PYQs in last 7-8 years or so. So in end, we'll try to discuss common PYQs also. So first, let's start without wasting any time. So, what are the high topics or on which you can expect a question, or and the topics which has been more frequently asked in NICET in last few years? Okay. So let's start with anesthesia delivery systems, and just let me see if the audio, video, everything is okay on YouTube. Uh, and the topics which has been more frequently asked in NICET in last few years. Okay, fine. Audio, video, everything appears to be okay. So let's see. Let's go. So anesthesia delivery systems means, as the name suggests, these are the equipment which are used for the delivery of anesthetic gases. And to deliver something, you must have source. So your source could be cylinders. So regarding cylinders, two most important thing that you should know. One is the color of the cylinder, and second is the pressure of the cylinder. So let's start with oxygen. Oxygen. The color of oxygen cylinder is black body with white shoulders. You can see also black body with white shoulders. And as far as pressure is concerned, the pressure is in a full oxygen cylinder is 2000 pounds per square inch. There are many units which are being used in different countries. So you may find different units in your books also. But of course, you just about one unit, that is PSI, which is most often used. So 2000 pounds per square inch. Second cylinder in common use is nitrous oxide, which is stored in blue color cylinders. You can see blue color cylinders at a pressure of 760 pounds per square inch. Third cylinder, which is important, is Antonox. Antonox is a mixture of 50% oxygen and 50% nitrous oxide. So half oxygen and half nitrous oxide. So the color is blue body with blue and white shoulders. So you can see blue body with blue and white shoulders. So blue body with blue shoulders indicating nitrous oxide, while white shoulders indicating oxygen. And the pressure is again 2000 psi. Why? Because that you all know a simple rule of physics. When you mix two gases with different pressure, the combination will always exhibit the pressure of higher gas. So if you get any gas mixed with oxygen, which has a lower pressure, like nitrous oxide pressure is 760, oxygen is 2000. So the total pressure will be 2000 psi. Then, not only through cylinders, gases are supplied through central supply, and central supply of oxygen, nitrous oxide, and air is at a pressure of 60 psi. In your books, you may find different answers in your books because in US it is supplied at 50, UK at 55. So depending on the source they have given the answer. However, in India, the central supply is at a pressure of 60 psi. And you can see the pipes have different color codes. So it is a white pipe, it will be for oxygen. Blue pipe will be for nitrous oxide. Black pipe will be for air. Yellow pipe will be for vacuum, or you can say central suction. Then another very important thing is that we should prevent wrong delivery of the gases. Cylinders are attached to anesthesia machine. So at that place, they have derived a pin index system. The aim of this pin index system is to prevent the wrong fitting of cylinders. So you don't fit wrong cylinder at different positions. So you can see it consists of two pins, and corresponding to the same pin position, there will be holes in cylinder. Now, this pin index position is defined for all gases. However, none of that gas is attached to the anesthesia machine in modern day practice. Only two cylinders which are attached to anesthesia machine are oxygen and nitrous oxide. So what you have to know is the pin index position of oxygen and nitrous oxide only. So pin index position for oxygen is 25, while that of nitrous oxide is 3.5 or 2.5. You can correct it. It is 3.5. For nitrous oxide is 3 and 5. What does that mean? Like this is the position and this is the place where oxygen cylinder will be fitted, for example, on anesthesia machine. So pin positions will be 2 and 5. And if this is a oxygen cylinder, the hole position will be 2 and 5. So that holes and pins will match with each other. So pin index for nitrous oxide is 3.5. Means if it is a nitrous oxide cylinder, the positions of holes will be 3 and 5. So you cannot fit a cylinder with the holes of 3 and 5 at a position of pins at 2 and 5. So pin index system is to prevent wrong fitting of cylinders to the anesthesia machine, and pin index position for oxygen is 2, 5, and that of nitrous oxide is 3 and 5. Then this is how a older anesthesia machine used to look. And older time we know that we used to say anesthesia machine as Boyle's machine. So this is a very basic Boyle's, and these are the positions where central supply or cylinders will be fitted. So they should have pin index here. Then, but nowadays, we have modern anesthesia machines which are called as anesthesia workstations. So modern day anesthesia machine appears like that, where pins will be at the back of the cylinder because central supply and cylinders are attached at the back of the machine. So another important component of anesthesia machine, you can say, is one is the rotameter. Rotameter is used to set the flow rates. So this is a rotameter. So which has knobs. By rotating these knobs clockwise or anti-clockwise, you can increase or decrease the flow of each gas into this flow meter tube. And this is structure called as bobbin. So it is the upper level of the bobbin which determine the flow rates. So by rotating this knob, you can increase or decrease the flow of gases through these flow meter tubes, and based on that you can set the flow rates. So simply you can say rotameter is used to set the flow rates. Another very important component of anesthesia machine is vaporizer. And vaporizer is used for the delivery of volatile agents, which may be halothane, isoflurane, desflurane, sevoflurane, whatever you are using. So now we can look at the anesthesia machine. You can see this is the rotameter where you can set the flow rates, how much you are want to give. And after that, these gases will pass through this vaporizer, which contains volatile agent. So volatile agent will mix with this gas mixture, and that can be delivered to the patient. Now, gases are delivered at the machine outlet, but to deliver these gases from machine outlet, these need to be delivered to the patient. For that, you need these tubings. So these tubings are called as breathing circuits. So breathing circuits are nothing. They are the connection between anesthesia machine and the patient for the delivery of these gases. So these breathing circuits may be classified as open. Open means you directly pour volatile agent over patient mouth and nostril, but these are obsolete techniques. So what we are using nowadays are semi-open and semi-closed or closed systems. So semi-open circuits were described by Mapleson. So they are called as Mapleson circuits, while semi-closed and closed systems are called as circle system. So first let's discuss semi-open circuits. As I told you, semi-open circuits were described by the scientist Mapleson. So they're also called as Mapleson circuits, which he has defined from A to F. So Mapleson A is also called as McGill circuit. You can see this is the machine end. Means this end will be connected to the machine, and this is the patient end, so it will be connected to the patient. So gases from this anesthesia machine will be delivered to the patient. Fine. And so this McGill circuit is the semi-open circuit. We are discussing semi-open circuit. Is the semi-open circuit of choice for a patient who is spontaneously breathing. Spontaneously breathing. See, now the problem of this every circuit is that when the patient expires, like for example, say this patient is expiring, this is expiratory gases. These expiratory gases may get retained in the tubing and patient may re-inhale these gases again. So this is called as rebreathing. So aim of every circuit is that there should not be any rebreathing. And to prevent rebreathing, they say you have to set a fresh gas flow, which should be sufficient enough first to push these expiratory gases out of this expiratory valve and then to be delivered to the patient. So this fresh gas flow recommendations for McGill circuit is that it should be equal to the minute volume. Fresh gas flow should be equal to the minute volume. Means if you are using McGill circuit and patient is on a spontaneous ventilation, then fresh gas flow coming from anesthesia machine should be equal to minute volume, or I can say around 6 liter for an adult patient. Out of this 6 liter, 75% should be nitrous oxide or air, 25% should be oxygen, and plus it contains one of the volatile agent. So this is what a combination we give to the patient. So McGill circuit is Mapleson A. It is the semi-open circuit of choice for spontaneous ventilation, and fresh gas flow for spontaneous ventilation should be equal to the minute volume. B and C are obsolete. A Mapleson D modification, that is called as Baines, is the most commonly used semi-open circuit, and it is a, what is difference in Baines? You can see there is an inner tube. That means this circuit is coaxial. Coaxial means one tube passing through the other. So what Bain did, he made an inner tube to pass through this outer tube. Can you see this whole inner tube along the length? So fresh gas will go through this tube. So there will not be mixing. Fresh gases through the inner tube, expiratory gases through the outer tube. So mixing is very less. That is why this Baines is most commonly used semi-open circuit. And it is the semi-open circuit of choice for controlled ventilation. And fresh gas flow recommendations are 1.6 times of minute volume. 1.6 times of minute volume means around 10 liter flow you have to keep from anesthesia machine, means through rotameter. Then other two pediatric semi-open circuits. Mapleson E was IRST piece, which was incomplete, but it was made complete by two scientists, that is Jackson and Rees, which is also called as Mapleson F. So Mapleson F, you can say, is the most commonly used pediatric circuit. In fact, this is the only pediatric used pediatric semi-open circuit, rather I will say. Most commonly used pediatric semi-open circuit. Then semi-closed or closed. You can see in semi-closed and closed circuit, what will happen? Expiratory gases will pass through the expiratory limb, and from there they pass through this canister containing soda lime. Soda lime will absorb the gases and the same gases can be reused. Now, since gases are not venting out into the atmosphere, so it used to be called as closed circuit. However, some gases do vent out due to some leakage, so they actually are semi-closed circuit. But nowadays they say that why to have these confusion terms? The best term for these are circle system. Simply you can say gases are in circulation, same gases are in circulation, so they are called as circle system. So one of the very important component of circle system is soda lime. Soda lime. Now soda lime, recently they have changed the composition, that now as per the latest soda lime, the calcium hydroxide constitute 80%, sodium hydroxide 3%, potassium hydroxide 1%, and they have added water. So they have decreased this soda lime to 80% and replaced it with 15% water volume. So this is the, you can say, very important latest change in soda lime available for last few years. Why? That we are just going to discuss. And there is a color indicator to tell whether the soda lime is fresh or has been exhausted. There are many color indicators. But the indicator which is most commonly used is pink when fresh and becomes white on exhaustion. White on exhaustion. So, what is the major advantage of this circle system? That it use low flows. See, same gases are in circulation. So only the few gases which has been leaked due to leakage or the oxygen consumed by the body just need to be replaced. So very low flow that makes anesthesia to become very economical, and then uh, less gases are venting out into the atmosphere. So there is very less theater as well as atmospheric pollution. Because of these regions, simply you can say that circle system is preferred over semi-open. So this can be very important, and you can expect a question like this. They will ask you circuit of choice for spontaneous ventilation. I know many of you will simply jump to say McGill circuit. No, it is the semi-open circuit of choice for spontaneous ventilation, not circuit of choice for spontaneous ventilation. Circuit of choice for spontaneous ventilation will be circle. Similarly, if they ask you circuit of choice for controlled ventilation, you will immediately jump to say vein. No, it is semi-open circuit of choice for controlled ventilation. If the circle system is there in choice, you have to choose it. Even forget about adults. If they ask you circuit of choice for pediatric patients, whether for spontaneous or controlled ventilation, don't jump to say Jackson Rees or Mapleson F if circle system is there in the choice. I know now, because honestly speaking, if you ask me, like last 7 8 years or so, hardly on occasions we are using semi-open circuit if circle system is not available. So please be careful. A very easy question can become wrong. If circle is available in the choice, you have to choose circle. For spontaneous, controlled, pediatric, anything, circle systems are preferred over semi-open in any and each and every case. Clear? But what are the disadvantages of and this circle system? The soda lime can react with inhalational agents to produce toxic compounds. So this soda lime do react with inhalation agent to produce toxic compounds. And the most classical example of that was trilene. Trilene used to produce toxic compound which could have caused neurotoxicity or could have even caused ARDS. But trilene is obsolete. However, the agents which we are using nowadays, they can also react with soda lime to produce toxic compound. For example, sevoflurane. Sevoflurane, by reacting with soda lime, produces a toxic compound called as compound A, which is nephrotoxic. Nephrotoxic. Then, if the soda lime is desiccated, desiccated means extremely dry. Then with the desflurane, it can produce carbon monoxide, and with sevoflurane, it can cause burns of the respiratory tract. So desiccated soda lime can produce dangerous complications. That is carbon monoxide with desflurane and burns of the respiratory tract with sevoflurane. But fortunately, the possibility of these complications are very rare because soda lime getting desiccated is very rare for two reasons. One, when carbon dioxide react with soda lime, water is automatically produced, which prevents soda lime from desiccated. And second, as I told you, that the latest available soda lime, they have reduced the calcium hydroxide from 95% to 80% and replace it with water volume of 15% so that soda lime doesn't get desiccated, preventing dangerous complications like carbon monoxide poisoning with the desflurane and burns with respiratory tract with sevoflurane. So all these things are very latest because nowadays the sevoflurane desflurane are more commonly used. So what I'm trying to cover in this session is which are the latest on which you can you can have possibility of getting questions, very high possibility. Then regarding equipments, embo bag. EMBO, you know, is also called as manual resuscitator, and this is being used for resuscitation. And by giving oxygen attachment and a reservoir bag, it is possible to deliver even 100% oxygen through EMBO bag. So these are some equipments related to that. You can always have pictures. Goodell's airway, again a very commonly used airway device, and this is used to prevent tongue fall. So it is placed between tongue and posterior pharyngeal wall, thus preventing tongue falling back on posterior pharyngeal wall, preventing the airway obstruction, because we all know that the most common cause of airway obstruction in unconscious patient is tongue falling back on posterior pharyngeal wall and obstructing the airway. Then LMA, very, very important. In last 10 years or so, you will see every exam there is a question on laryngeal mask airway. If not, then alternate exam you see a question on laryngeal mask airway. So this is LMA, which has a tube, and you can see this is a large cuff which can be inflated with large volume of air, and these are the ventilation holes or ventilation ports. So this is how LMA work. You placed it blindly in oral cavity so that this part lies in oropharynx. When you inflate with large volume of air, it will get sealed from all sides, and then you can see these holes. When you ventilate through this tube, air has no option but to go to larynx. So basically, what are the advantages of LMA? It can avoid all complications of intubation. It's an alternative to intubation, and intubation, you know, has plethora of complications. So you can avoid all complications related to intubation. However, the disadvantage is that there is increased risk of aspiration because it is not blocking the esophagus. It is just resting over the esophagus. So air can still leak from sides and can increase the intragastric pressure, increasing the risk of aspiration. So risk of aspiration is increased. And so now we have different kind of LMA also. Flexible LMA, the tube is flexible so that this tube doesn't get kinked even with different positions of the neck. And then Embu LMA, Embu is just a company. Actually, this Embu bag I've seen, and this actually is a company. So they are manufacturing LMA also. So this is a Embu LMA, and normally their code is green color. Actually, bag and everything they made it of green color. Now, when you start to use something very commonly, you start to increase its uses. Now we have special kind of LMA which can be used to intubate. You can see intubating LMA through the LMA. So what will be the difference? Instead of these small holes, there will be big hole. So you can place a tube. The tube will come out of this hole, and tube cannot slip anywhere. So it will enter the trachea. So you can see also a tube is being pushed through this, and through this hole it will come out. And in fact, you have now LMSC track. Means you can see your movement of the tongue directly on a screen also. There is a video camera attached here. So you can just see the image and you can guide your tube into the vocal cord. That is called as LMSC track. Now I told you, these all LMA what we have discussed so far, all these are actually first generation LMA. So they can be classified as first generation and second generation. So the difference between first generation and second generation is, I told you that the biggest problem of LMA is aspiration. Now, why aspiration occur? Because there occur gas leakage from the sides, which increase the intragastric pressure. Now, you cannot deflate the stomach also. How will you deflate the stomach? Because cuff has occupied all of the oropharynx or hypopharynx, or from where you will pass the suction catheter or your Rayleigh tube. So this problem is not there in second generation LMA, because in second generation LMA, there is a separate tube for gastric deflation. And the prototype of second generation LMA is ProSeal. So this is a ProSeal. You can see there is a tube for gastric deflation. So through this tube, you can pass your suction catheter Rayleigh tube, and through this hole, it will enter the esophagus. So this hole actually should be resting over the esophagus, So this is ProSeal, which is a prototype of second generation LMA. So how to differentiate first and second generation LMA? Just by looking at if it has a separate tube for stomach decompression, and definitely there should be hole air. From this, your tube or suction catheter can enter the esophagus. That's how you differentiate first generation and second generation LMA. All these, even this intubating LMA, there is no option for stomach decompression. Even this EMBU LMA, it doesn't have, if it is first generation, although second generation is also available, then flexible LMA also doesn't have. Then eye gel is also very commonly used in India, and eye gel, the cuff is filled with a gel. So all these cuff related problems like accidental deflation of cuff leading to displacement of LMA, these all can be avoided because cuff is pre-filled with a gel, and it is of considered as second generation because you can see there is a tube through which you can pass your suction catheter tube, and through this hole it will enter the esophagus. LMA Supreme, again type of a second generation. You can see there's a hole and there's a separate tube for stomach decompression, and this has a proper bite block also so that patient doesn't uh, bite the LMA tube. Then EMBU LMA, I told you to manufacture both first and second generation LMA. This is second generation because you can see there is a hole for stomach decompression. Face mask, they are used for ventilation, but only as a transient period till you are able to put LMA or able to intubate the patient. Why? Because one of the biggest disadvantage of mask ventilation is that there is tremendous increased risk of aspiration. Because with mask, if you are giving positive pressure ventilation, or air will leak into esophagus, will increase intragastric pressure, increasing the risk of aspiration. So risk of aspiration is tremendously increased with mask ventilation. Then laryngoscopes are used to facilitate intubation. There are many kind of laryngoscopes used, but Macintosh is the most commonly used, and it is the laryngoscope of choice for adults. It has a curved blade. How do you identify? It has a curved blade. So Macintosh is most commonly used, and it is used for adults. Then second most commonly used is pediatric, that is Miller, which you can say is a straight blade, almost a straight blade. A little curve is there, but almost straight blade. So Miller is used for pediatric children, all ages. This is again a very important change from recent advancement point of view, because previously we were using different blades for different pediatric age groups. 3 or 4 different kind of blades are being used. But now for children, irrespective of the age, even for a newborn, the blade of choice or the laryngoscope of choice is Miller. Again, important from a recent advancement point of view. Then endotracheal tubes. Endotracheal tubes obviously are used for intubation. And the most important characteristic of present day used PVC tubes, these are the PVC tubes, that their cuff, this cuff is low pressure. Low pressure and high volume. Low pressure and high volume is the most important characteristic of current day PVC tubes. Low pressure cuff, obviously pressure is low, so there is less chances of tracheal ischemia. Less chances of tracheal ischemia. So that's the biggest advantage. That's why we are using PVC tubes nowadays. There are many other advantages also, like you can see they are transparent, so any secretion or mist can be visualized. Theoretically, they say that there is one disadvantage of low pressure. Since pressure is low, so they say the chances of aspiration is little high compared to the tubes which were using in the past. They were high pressure, but this is absolutely theoretical. But yes, theoretically you can say, but otherwise, yes, no. But yes, theoretically, yes, the chance of aspiration is little increased because of the low pressure, but that is actually not true. Means from clinical point of view, it is not so. Theoretically, yes, it is true. Now, cuff, another very important thing is that now we can use cuff tube in children. Previously, we were not using cuff tube in children, believing that cuff can touch the tracheal wall, can cause tracheal wall edema. Subglottis is the narrowest part, so there can be subglottic edema also. But all these things have been unfounded. There is no difference in increase incidence of subglottic edema or tracheal edema with the cuff tube. So therefore, now cuff tube can be used in children at all ages. Now, very important how to confirm the position of the endotracheal tube. You can look at the chest expansion, you can look at the auscultation, but even auscultation can misguide you. Surest confirmation of intubation is only and only possible with capnography. So capnography, which is the measurement of end-tidal carbon dioxide, 100% confirm that your tube is in trachea. And obviously CO2 will come out of endotracheal tube only if the tube is in trachea. Then there are other many kinds of tubes which are being used, but the very commonly one I'll tell you is flexometallic tube. You can see this metallic wire. The presence of this metallic wire make these tubes to become flexible, non-kinkable. And because of this non-kinkability, it is excellent for head and neck surgeries because even in extreme flexion or extension or movement of the neck, it is not going to get kinked. You can see from this image also that in spite of putting a knot, it is not getting kinked. Then preoperative assessment. Basically, preoperative assessment is done to assess if the patient is suffering from any medical disease. Based on that, we can plan our anesthesia or we can medically stabilize the patient. So that was like a normal general physical examination, systemic examination of cardiovascular system, respiratory system. But one system that is absolutely our responsibility to manage and we should assess beforehand is airway. So in airway assessment, this modified Mallampatti scoring is done to assess the mouth opening because we have to intubate the patient through oral cavity. So there should be adequate mouth opening. So we see structures like in modified Mallampatti, we see fascial pillars, soft palate, and uvula, and in fact, we also see the fauces. Fauces is the entry point. So these four structures are seen: fascial pillars, soft palate, fauces, and uvula. And based on the structure seen, patient has been classified into four categories. Class 1 and 2, majority of the structures are seen, so intubation should be easy. Class 3, less structures are seen, so it should be difficult. And class 4, nothing is seen, so oral intubation will not be possible. Then pre-medication, we pre-medicate the patient. However, routine medication is not advisable. Pre-medication should be done only with a clear-cut goal. And there are many goals or aims, but you can say the most important goal in present day practice, if you ask me, to pre-medicate the patient is to relieve the anxiety. And of course, to relieve anxiety, you can give benzodiazepines, whatever benzodiazepine you want to give as per your institute practice and per your comfort. Now, another very important thing, the common questions which has been asked in last 7 years is management of the pre-existing drug therapy. If the patient is already on drug therapy, that can have anesthetic and surgical implications. So what are the guidelines for that? To be stopped Viagra 24 hours before surgery. Why? Because Viagra causes sympathetic stimulation and surgery and anesthesia itself are, you can say, uh, sympathetic stimulating conditions, stressful conditions. Anticoagulants, warfarin, most commonly used 5 days. Other, if they ask you by chance, although they will ask mainly warfarin from you, but by chance, if they ask you other directly acting oral anticoagulants, it is different for different, but just as a random, if you want to attempt, then just go for a choice of 48 hours. 99% you will be correct. That may be dabigatran or uh, whatever is the direct acting oral anticoagulant, rivaroxaban, dabigatran, whatever. Yes. Antiplatelets, aspirin to be stopped 72 hours before. This is a very recent change. So more important from questions point of view, because previously we were continuing aspirin, but now they found that even if you continue or don't continue, there is no difference in incidence of perioperative MI. So rather continuing can increase the risk of bleeding. So therefore now they stop 72 hours only and they continue in three conditions. If a patient has recent MI within 2 months, recent strokes 2 months, within recent stroke within 9 months, or if the patient is having some coronary stent, then only in these conditions, three conditions, we will continue. Rest we have to stop 72 hours before. Clopidogrel, previous recommendation was also 5 days. Current recommendation is also 5 days. Oral contraceptives only if they're high dose estrogen, which should be stopped 4 weeks before because estrogen increase the risk of thromboembolism. However, if patient is on low dose estrogen or only progesterone, we continue. Herbal medications, we stop 7 days before. This is again a change because previously it was uh, 2 weeks, but now 7 days. And why we're stopping herbal medications? Because there are not enough studies to prove the side effects. We don't actually know what are the side effects, but herbal medications have many side effects, but there are no studies to know about the side effects. So we don't want chance and we stop all these herbal medications 1 week before. Another very important thing is AC inhibitors and angiotensin receptor blockers. They should be stopped 24 hours before. Why green? See, wherever I'm using green pen means these are the, what you would have noted by this now, that these are the recent advancements, so they are more important. So AC inhibitors and ARB should be stopped 24 hours before. Rest all antihypertensive we have to continue. And why green pen? Because previous recommendation was to stop these drugs on the day of the surgery only. Smoking, we have to stop 8 weeks before. Why? Because smoking inhibits cilia and they say complete ciliary recovery occurs in 8 weeks. Morning dose to be omitted for diuretics if not taken for hypertension. If taken for hypertension, we continue because all antihypertensives, we have to continue. Topical creams, we have to stop. Why? On the day of the surgery, because they have chemicals which can react with the antiseptic solutions which surgeons are going to use, and that can cause severe skin reactions. Oral hypoglycemics also should be omitted on the day of the surgery. Modifications required in cholinesterase inhibitors, that is neostigmine, pyridostigmine. Why? Because if you continue them, they can antagonize the effect of muscle accent. If you stop them, patient can develop myasthenic crisis. So they are continued, but in lowest doses. So that is a modification. Steroids, based on the doses, based on the route. If a patient has taken steroid in last 1 year, we supplement with the perioperative steroids. And now there are different regimes. So you can say steroids to be continued, and but with modifications. ATT, we do continue subject to condition if patient LFT are normal. If LFT are normal, then only we are going to continue ATT. Fluids. Now, again, I will use green pen. Fluid for maintenance nowadays is ringer lactate, irrespective of the anesthesia, irrespective of the age. Previously, due to different regions, we were giving different fluids for pediatric patient, different fluids for geo, different for regional. Now, fluid of choice for maintenance, irrespective of the age, irrespective of anesthesia, is ringer lactate. So again, that is important from a recent advancement point of view. Replacement fluid, crystalloids are always preferred. And why crystalloids are preferred? And among crystalloids, RL is most preferred. Why? Because RL is most near to the body fluids. Monitoring is a very important part of anesthesia, and it is your monitoring standards only which define your quality of care. So for monitoring the depth of anesthesia, we have two monitors. One is entropy, and all these are both are EEG based. They analyze multiple EEGs to give you scores, and on the basis of that scores, you know the depth of anesthesia. Entropy or BIS index, bispectral index monitor. Bispectral index, BIS index. BIS index is most commonly used, but entropy is new and is considered as uh, most commonly used. So if they ask you most commonly used to see the depth of anesthesia, it is bispectral index monitor. But nowadays you may expect question on entropy also. So entropy has certain advantages over BIS. So if you get a question that which is the best monitor to see the depth of anesthesia and choices, if entropy is also there, then you have to choose entropy over BIS. So you have to see which way they have asked. If they ask you most commonly used, it is still bispectral index. But if it asks you preferred and entropy also choice, then you have to choose entropy. Then cardiovascular monitoring. Invasive blood pressure monitoring is considered as gold standard for BP monitoring. So if they ask you what is the gold standard for blood pressure monitoring, it is invasive blood pressure monitoring. Invasive means you have to cannulate one of a artery, and the most commonly cannulated artery is radial artery. Radial artery. And why it is gold standard? Because it is continuously measuring the blood pressure along with the waveform. Waveform is also very informative. However, there is a risk that when you cannulate a artery, there is a possibility artery will go in a spasm and there can be possibility of ischemia of the hand. So there, and why we are preferring radial, because we all know that there is an alternative solution is through ulnar artery, which form transformer arch. So we have to see the patency of this ulnar artery before cannulating a radial artery, and that is done by Allen's test. So what do? We completely exsanguate the hand, and then we occlude both radial and ulnar artery. Now release pressure from ulnar, still maintain pressure on radial. If the color of hand returns to normal within 7 seconds, that means ulnar circulation was patent, and you can easily cannulate the radial artery. So before cannulating radial artery, we have to check the patency of ulnar artery. Ulnar artery, or other words, you can say transpalmar arch by modified Allen's test. Modified Allen's test. Then another very important change, you know that previously we were preferring lead V5 for ischemia, but now V3 is preferred over V5 for ischemia. Again, a very, very important from recent advancement point of view, which you can expect a question. In fact, they found for ischemia, even V4 is more sensitive than V5. Forget about V5. So now the lead of choice for detecting ischemia and perioperative period is V3, followed by V4 and then V5. Otherwise, traditionally, for decades and decades, we were using V5. But the best is transesophageal echocardiography. It is so sensitive that it can detect MI in more than 95% of the patients. Sensitivity of detecting MI is 95%. With ECG, changes may not happen in one third of the patients up to many hours. While transesophageal echocardiography can detect MI and all other cardiac functions in real time. So it is considered as the best cardiac monitoring. So if they ask you best cardiac monitoring for perioperative period, it is TEE, that is transesophageal echocardiography. Respiratory monitoring, the most basic is pulse oximetry. But the disadvantage of pulse oximetry is that it cannot detect abnormal hemoglobin. So if the patient is suffering from any kind of methemoglobinemia, sulfhemoglobinemia, these pulse oximeter will not be able to detect. So these abnormal hemoglobins can be only detected by co-oximeters. So that is why co-oximeters are considered as gold standard for oxygen saturation measurement. So by chance, if they ask you what is the gold standard for measurement of oxygen saturation, I know many of you would have jumped to say pulse oximetry. No, it cannot detect abnormal hemoglobins, so it cannot be gold standard. So co-oximeters, since they can detect abnormal hemoglobin, so they are the gold standard for oxygen saturation measurement. Capnography is the most sensitive respiratory I will say monitor, which can give you details of the every breath. And we already have discussed that it confirms intubation. How? Because if the tube in trachea, then only CO2 will come out of endotracheal tube, which you can measure. So it can obviously detect accidental extubation. And when the tube has been pulled out or accidentally slipped into esophagus, then CO2 will not come out of the endotracheal tube. So the value will become zero and the graph will become flat line. CO2 graph is going to become flat line. So let's see the graph, how the capnography graph appears. Again, very, very important. Many questions you will see in exams on capnography graphs. Very, very common, very important. So how a normal graph for mechanically ventilated patient appears is like this. So this is a graph for a mechanically ventilated, means controlled breath, controlled by a ventilator. However, for a spontaneously breathing patients, the graph is like this hill shape. Can you see this hill shape type of graph is there? So you can differentiate. For a controlled breath, the graph is like this, while for a spontaneous breath, the graph is a hill shape type. Abnormal graphs which you commonly encounter for COPD, asthma, or you can say bronchospasm, in fact, clearly. Bronchospasm. What happens in bronchospasm? Expiration will be prolonged. So you can see upsloping expiration. And last part of expiration is upsloping. And this shape gives the shark fin pattern. So shark fin pattern on capnography represent bronchospasm. Then if soda lime is exhausted, CO2 will not get absorbed. So inspiratory CO2 will come and increasing the baseline. So if baseline is increased, that means patient is inspiring CO2. So soda lime is exhausted. We can identify exhausted soda lime by color also, color of the indicator. Before that, we have already diagnosed exhausted soda lime by looking at the CO2 graph, which has shifted the baseline. It's not coming to zero. Then recovery of spontaneous breath is represented by curare notch. Can you see this curare notch? So this curare notch represent that patient breath has been recovered. That means how we achieve the controlled ventilation by paralyzing the patient by giving muscle action. So when the effect of muscle action will wane off, the patient will try to take his or her spontaneous breath, which is represented as curare notch, So this curare notch represents that patient spontaneous breath is recovered during controlled ventilation. So what is the solution? Obviously, we have to repeat the dose of muscle relaxant. So even dose of muscle relaxant, we are repeating by capnography. Then EtCO2 becoming zero. You can see it was going normal. So the normal EtCO2 is around 3 to 4 mmHg less than RTL PCO2. So you can say somewhere around 37, 38, or range you can say is 32 to 42, normal. So 37, 38, 32 to 42 is the normal range. So you will see suddenly it becomes zero. It becomes zero. The first thing that should be coming to your mind that there may be accidental extubation. If there is no tube is not present in trachea, I told you from where CO2 will come out. Or apnea, no ventilation, no CO2. So zero. Disconnection, very common. In fact, this I will say EtCO2 becoming zero. I won't mind saying that this is the most common cause. In practice, this is the most common cause that EtCO2 becoming zero means tube has got disconnected from the circuit. Disconnected from the circuit means if tube is disconnected from circuit, how CO2 will reach monitor, so it will again become zero. Or if the tube is completely obstructed, although tube getting completely obstructed during anesthesia is rare. ICU, it can happen when patient is in on a ventilator for months, then these thick secretions can block. But yes, if tube is completely obstructed, how CO2 will reach monitor? So it will again become zero. So all these are life-threatening complications, even in cardiac arrest, when there is no blood coming from periphery, how CO2 will reach lungs. So again, it will become zero. So these are life-threatening situations which you can detect within minutes with capnography. Not minutes, within seconds, in fact, I will say, on the very next breath. Temperature is also considered as uh, mandatory monitor. But regarding the sites of core body temperature measurement, actually, to say hypothermia, we have to rely on the measurement of the core temperature. Now, regarding the core temperature measurement site, the most accurate site they say is pulmonary artery. But pulmonary artery cannulation is not practically possible. So that is not done in spite of being accurate. The most commonly used, or you can say best, is the lower end of esophagus. The probe is like Ryle's tube placed in esophagus and connected to a regular monitor. Then GA. So for GA, what we do, induction, we do, see what is the protocol for GA. I'll just you try to make you understand what we do in GA. Uh, Before starting the anesthesia, we have to pre-oxygenate the patient. Pre-oxygenation is very important. Normally, it is done with 100% oxygen for 3 minutes. So, what will happen with by giving this 100% oxygen for 3 minutes, you are you will be able to replace nitrogen present in lungs with oxygen, so that now whole of the lung is filled with oxygen. So, patient will be able to sustain hypoxia for longer periods. So, first thing what we do is pre-oxygenation, which is 100% oxygen for 3 minutes. Then we do induction, and induction is done with IV agents. Why? Because they are ultra fast acting. Within 15 seconds, they'll make the patient to become unconscious. Then we give muscle laxant because we have to paralyze uh, the laryngeal muscles, then only we'll be able to intubate. Until the effect of muscle accent come, we continue ventilation of the patient. And as soon as the effect of muscle accent come, we intubate the patient, verify the position of tube by capnography after inflating the cuff of the endotracheal tube. And then anesthesia will be maintained on. Maintenance of anesthesia will be with 75% nitrous oxide or air plus 25% oxygen and plus one of the volatile agent. And relaxation for surgery will also be required. So that is maintained with non-depolarizing type of muscle action because they're long acting. Then at the end of surgery, you have to reverse the effect of these non-depolarizers by giving neostigmine. And then patient is extubated. So that is what we do in general anesthesia. So IV agents, I told you they're used for induction because they're ultra fast acting. So among IV agents, thiopentone used to be used commonly previously, but now it is obsolete. The most important reason why it obsolete was its half-life was 10 hours, 10.3 hours. So such long half-life, obviously drug is not acceptable. The drug remaining in body for such long period is not acceptable. So that was the main reason which led to obsolescence of thiopentone. Another very important property, it has got alkaline pH, and we'll just see the significance of this alkaline pH. Then at advantage it that it is a very strong anticonvulsant. In fact, epilepsy not controlled by any drug is finally controlled with thiopentone. And for this purpose, actually we are using thiopentone in ICU for refractory status asthmaticus. So we are using it for refractory status asthmaticus. Then I told you one of the problem with this alkaline pH is that if it get accidentally into arterial injection, means into an artery, there can occur even gangrene of the hand. And this usually occurs if it is given in antecubital fossa, because in antecubital fossa there is close proximity of the brachial artery. So what will happen, because of its alkaline pH, it will get precipitated, and this precipitated thiopentone can cause endothelial injury. And whenever there's endothelial injury, artery goes in spasm. So there's intense vasospasm. So limb distal to the vasospasm become at risk of ischemia. So what we have to give? We have to inject a vasodilator because it is because of vasospasm. And the most preferred vasodilator is papaverine. Papaverine. If not available, you can use any of the vasodilator, phenoxybenzamine, or even lignocaine you can also use because that's also a locally acting vasodilator. But thiopentone, I told you, nowadays is not very commonly used, very rarely used because of its long half-life. So what we are preferring nowadays is propofol, and the most important reason for preferring propofol is that its half-life is short, around 2 to 3 hours. And it is a milky white solution prepared in soybean oil. So injection is painful. So obviously it's a oil-based preparation. So injection is painful. Then it contains egg lecithin. It contains egg lecithin, and you know that egg is a very good culture media for bacterial growth. And in fact, there has been case reports of death due to septicemia because of the use of contaminated solution of propofol. So therefore, propofol, while once opened, you have to discard within 6 hours. Very important. You have to discard within 6 hours. Then half-life, I told you, is the single most important reason for which propofol has replaced thiopentone. Then a very, very unique property of propofol is it is a anti-emetic, very strong anti-emetic. And so because of that, I told you it is the IV induction agent of choice for routine induction. Almost always we are using propofol. And of course, it is also the IV induction agent of choice for daycare surgery because of its shorter half-life. Etomidate, another IV agent that is being used. However, it is only used for cardiac patients because it is most cardiovascular stable, most cardiac stable. And why we are restricting it use only for cardiac patient because it can cause adenocortical suppression. There is a possibility of adenocortical suppression. Although this is rare, but when it happens, it's a dangerous complication. Benzodiazepines. Benzodiazepines are mainly used in anesthesia for two purposes: as anxiolytics or to produce amnesia. These are the purposes, although you know that in very high doses, they can be used for induction and not used for that purpose at all. But of course, they are so much, you can say, sedative. In very high doses, they can be used for induction also. We are not using, as I told you. So they are used as anxiolytics and amnesia. And the most commonly, not only most commonly, rather, I will say the only benzodiazepine which is used in intraoperative period nowadays is midazolam. And the most important reason is its short half-life. So because of the short half-life, around 2 to 3 hours, we are using only and only midazolam in intraoperative period. Other benzodiazepines are not used. Ketamine, we all know, produces dissociative anesthesia. That means patient is not only dissociated from surroundings, he or she get dissociated from himself or herself also. So ketamine is a unique drug which has certain clear-cut advantages and certain clear-cut disadvantages. So what are the advantages or uses? It is the IV agent of choice for shock. Why? Because it stimulates sympathetic system. So stimulation of sympathetic system will make it an IV agent of choice for shock because it increases BP. Then it maximally preserve airway reflexes, making it IV agent of choice for full stomach patients. Then it is a very, very potent bronchodilator, making it as an IV agent of choice for active asthma. In fact, it is such a potent bronchodilator that it can be used even for the treatment of refractory status asthmaticus. So potent bronchodilator. But disadvantage, I told you, it has certain clear-cut disadvantages. The biggest disadvantage or limiting factor for ketamine for not making popular is its vivid reactions, which most commonly manifest as hallucinations seen in almost half of the patients. Then the best way to decrease or treat these hallucinations or prevent these hallucinations is benzodiazepines, that is midazolam. Then second disadvantage, it can increase all pressures: intraocular pressure, intracanal pressure, or intragastric pressures. All pressures are also increased with ketamine. Opioids, they are used in anesthesia for analgesia. Of course, analgesia. And the major side effects, I will say, is the respiratory depression, which you all know is the most common cause of death in opioid poisoning. Second, they can cause muscle rigidity, and sometimes this muscle rigidity may be so severe in thoracic muscles that whole thorax become like wood. That is called as wooden chest syndrome. All these pure agonist opioids, they can cause wooden chest syndrome, but maximally it is seen with alfentanil. Maximally it is seen with alfentanil. Then alpha 2 agonist, they are used in anesthesia as adjuvant and sedation. And for that purpose, now dexmedetomidine is commonly used. So you may expect questions because in fact, dexmedetomidine is now recommended to produce sedation even outside OT also by FDA. So outside OT, you will see dexmedetomidine is also commonly used. So they may ask what is the purpose of dexmedetomidine. Inhalation agent, I told you they are used for maintenance. They are used for maintenance. So one of the very important property of these inhalation agents is their potency, which is described by their minimum alveolar concentration. So lesser is the concentration more required to produce the anesthesia, more will be the drug. So MAG you can say is inversely proportional to potency. So most potent among the agents of the current use agents, four volatile agents which we are using are halothane, isoflurane, desflurane, and sevoflurane. And one gas that we are using is nitrous oxide. So most potent is halothane, while the least potent is nitrous oxide. Second property is blood gas coefficient or blood gas solubility, which indicate induction and recovery. Means say if a agent is less soluble in blood, it will be easy for brain to extract it from blood, so induction will be faster. Means the lesser the blood gas solubility, faster will be the induction and recovery. So overall, fastest induction and recovery seen with xenon, but xenon is not yet available for clinical use. So among the agents of the current use, you can say the fastest induction and fastest recovery is seen with desflurane. Desflurane. Slowest induction and slowest recovery is seen with halothane. Individual agents, nitrous oxide, the most important property or side effect, I will say, which you have to know about nitrous oxide is that it is 35 times more soluble than, not air, you can correct it, it should be more soluble than nitrogen. 35 times more soluble than nitrogen. So that means for 1 mole of nitrogen removed will be replaced with 35 molecules of nitrous oxide. So imagine if this air is present in closed space, patient is suffering from pneumothorax, pneumomediastinum, pneumopericardium. Imagine for 1 mole of nitrogen removed getting replaced with 35 molecules of nitrous oxide. So imagine how fast a small pneumothorax or pneumopericardium can become tension pneumothorax and tension pneumopericardium, which can even kill the patient. So therefore, nitrous oxide is absolutely contraindicated in the situations where there is air in a closed space. Second, nitrous oxide, all anesthetic gases can cause ozone depletion. However, nitrous oxide, since we are giving in higher concentration, so it is most responsible for causing ozone depletion. That is why, if you remember, I told you anesthesia maintained with 75% nitrous oxide or air. So if you are environmental concerned, then people are using air in place of nitrous oxide. And considering these properties, well, now actually they are doing studies on xenon because xenon has no side effect like nitrous oxide, no expansion of cavities, no ozone depletion, good in anesthetic properties also. So and it's an inert gas also. So considering all these factors, you can say that xenon is actually an ideal inhalational agent. But in spite of being considered as ideal inhalation agent, xenon is still not used because it is still very, very expensive, too expensive to afford, in fact. Halothane, already we have seen, most potent, slowest induction and slowest recovery. Halothane sensitized myocardium to catecholamines. So this is a special effect of uh, halothane that sensitizes myocardium to adrenaline, increasing the risk of arrhythmia in presence of catecholamines. And that is why halothane is absolutely contraindicated for pheochromocytoma. Absolutely contraindicated for pheochromocytoma patients. Then halothane can cause hepatitis, very well known entity. Hepatitis can be seen with halothane. And this halothane hepatitis has got autoimmune basis. Means some of the metabolic product of halothane is antigenic, produces antibodies leading to antigen antibody mediated hepatitis. Isoflurane has got irritating induction. Isoflurane minimally decreases the cardiac output, making it as an inhalational agent of choice for all cardiac patients, including MI. Actually, very important recent change. because it is proven that it does not causes coronary steel. So again, a very, very important point from a recent advancement point of view, because for decades and decades, we are saying that isoflurane is the inhalation agent of choice for all cardiac patients except MI. But now it is the inhalation agent of choice for all cardiac patients, including MI, because it is proven that it does not causes any coronary steel. Then desflurane again has got irritating induction. And desflurane, we already discussed that with desiccated soda lime, it can produce carbon monoxide. So the major advantage of desflurane, you can say, is that it is minimally metabolized. And because of this minimal metabolism, it does not produces fluoride. And fluoride, all know can cause nephrotoxicity. No fluoride, making it as a inhalational agent of choice for renal patients. Renal patients. Sevoflurane is the inhalation agent of choice for pediatric induction. Why? Because it has got smoothest induction. So this is the inhalational agent of choice for pediatric induction. If they ask you induction agent of choice for a child, pediatric patient, induction agent is always IV propofol. But the problem is sometimes children are coming without IV lines. So we have to directly induce them by inhalation induction. So inhalation induction agent of choice is uh, sevoflurane, not the agent of choice. So be careful. Asthma, because it causes maximum bronchodilation. Rather, I will use green pen because some of the older books you may find halothane being mentioned as agent of choice for asthma, because now it is proven that it is better than halothane in bronchodilation. Then for neurosurgical patients, also I will use green pen because you may find that inhalation agent of choice mentioned is isoflurane, but that is again older. Recent evidence have found that isoflurane increases intracranial pressure, not IOP. You can correct it. This is intracranial pressure, not intraocular pressure. So minimum increase in ICP making as an inhalation agent of choice for neurosurgery. Hepatic patients, it is also most preferred. Why? Because it causes least decrease in hepatic blood flow. Muscle relaxants for neuromuscular monitoring, the ideal muscle is corrugator supercilii because they say head and neck muscles go together. So it parallel the laryngeal muscles, but it is not possible to apply electrodes over the face. So therefore, most commonly used for neuromuscular monitor is adductor pollicis, which is supplied by ulnar nerve. Ulnar nerve. And there are many modalities which are being used. You can simply remember that the most commonly used modality is Treno 4, where we are giving 4 successive stimulus, you can see. And after giving 4 successive stimulus, we see the response. And based on that, we can determine the depth of muscle relaxation. Muscle accents, are depolarizers and non-depolarizers. Depolarizer that is being used is succinylcholine, and it is ideal for intubation. However, it has many side effects. Therefore, we are restricting it only for difficult intubation. Otherwise, it is the ideal muscle accent for intubation because why? Onset is very fast within 30 seconds. Duration is also short, less than 10 minutes. And so why short duration? Because it is rapidly metabolized by pseudocholinesterase. So what are the systemic side effects? The most important being is hyperkalemia. Why? Depolarizing muscle accent means it produces muscle relaxation by causing persistent depolarization will make the membrane to become refractory for a transient period. So persistent depolarization, contraction will produce hyperkalemia. Then like ketamine, succinylcholine also increases intragastric pressure, intraocular pressure or intracranial pressure. Then for malignant hyperthermia, you know that succinylcholine is the most commonly implicated drug to trigger malignant hyperthermia. Non-depolarizers, they are long acting, so they are mainly used for maintenance of surgical relaxation because during surgery relaxation is maintained, otherwise how surgeon will do the surgery. So among non-depolarizers, agents of the current use, vicuronium. The best part of vicuronium is most cardiac stable, making it as a muscle relaxant of choice for cardiac patients. Cardiac patient, most cardiac stable. Atracurium is unique in the sense that it is metabolized spontaneously. And this spontaneous metabolism is called as Hoffman degradation. Since metabolized automatically, so it is not dependent on liver for its metabolism, making it as a muscle laxant of choice for hepatic failure. And guaranteedly metabolized means no risk of accumulation, also making it as a muscle accent of choice for renal patients. Cis atracurium has lesser side effect than atracurium. So of course, cis atracurium will always be preferred over atracurium. Although because of its cost, it is not commonly used in India. Otherwise, cis atracurium is definitely preferred over atracurium because of its lesser side effects. So if they ask you muscle accent of choice for hepatic failure or renal failure, and cis atracurium is also given in the choice, then definitely you have to choose cis atracurium over atracurium. Rocuronium, rocuronium has fast onset. Onset of non-depolarization is very slow, 3 minutes. Rocuronium onset is within 90 seconds, making it as a non-depolarizer of choice for intubation. If there is some contraindication to suxamethonium or you don't want to use suxamethonium due to side effects, then the non-depolarizer of choice for intubation you should prefer is rocuronium because its onset is faster. A derivative of rocuronium was synthesized few years back. However, it was withdrawn from the market and labeled as banned drug, and that was rapacuronium. Rapacuronium. And why it was withdrawn from the market? Because it caused intense bronchospasm, the incidence of which was around 10%. Mivacurium is also a non-depolarizer metabolized by pseudocholinesterase, making it as a muscle relaxant of choice for daycare surgery, short duration. Why can't we prefer for suxamethonium for daycare surgeries? Because of the side effects. So mivacurium cholinesterase, short duration, making it as a muscle accent of choice for daycare surgery. Now, after giving muscle accent, we have to reverse the effect of this muscle accent. And the most commonly used drugs to reverse this effect is cholinesterase inhibitors. And in cholinesterase inhibitors, the only one that is being used is neostigmine. So what these cholinesterase inhibitors do? They will inhibit acetylcholinesterase, which will prevent the degradation of acetylcholine, making more acetylcholine available to have competitive antagonism with non-depolarizers. Because you know that non-depolarizers are competitive antagonists at acetylcholine, and competitive antagonism is a pure number game. So more molecules of acetylcholine will be able to replace non-depolarizer from their place. But the problem is that this increased acetylcholine will also have muscarinic side effect. So to combat this muscarinic side effect, we have to give anti cholinergic drug, which can be glycopyrrolate or atropine. And nowadays, we are preferring glycopyrrolate because glycopyrrolate does not crosses the blood-brain barrier. So when we say reversal agents means neostigmine and glycopyrrolate, which I told you is done to prevent the muscarinic side effects. Second group of drugs other than cholinesterase inhibitors is gamma cyclodextrins that is available in the brand name Sugammadex. So Sugammadex, it directly bind to muscle relaxant, directly like a magnet. And so the effect is immediate and it can reverse very deep block. The problem is neostigmine, it's going to take time and it cannot reverse deep block. So it is very useful for situations where you need immediate reversal. Like for example, to reverse rocuronium. Rocuronium will not get metabolized by itself. So say you have given rocuronium, which is the non-depolarized of choice for intubation, and you're not able to intubate and not able to ventilate. Patient will die because rocuronium duration is 30 minutes. You cannot keep the patient in hypoxia for 30 minutes. So that comes, that in that situation, Sugammadex really come as a savior. Very important. But we are not using routinely because of its very high cost. Then some complications of GA. Aspiration is considered as preventable complication. And what are although not always possible to prevent, but yet is still considered as preventable. And what are the best method to prevent aspiration? Keep the patient fasting. And the fasting recommendations are for solid food 6 hours. Fatty non-vegetarian food, 8 hours. Clear fruits means water. Plain juices or tea and coffee without milk, 2 hours. While breast milk can be given up to 4 hours. But sometimes this prevention is only possible for elective surgeries. If the patient come for emergency surgery, patient is not fasting, patient is full stomach, but we have to take because of the emergency surgery, and you have to give GA also. So if you have to give GA to the patient who is at high risk of aspiration, the kind of technique that we follow is called as rapid sequence induction, RSI. So the difference in RSI from normal method of GA that we discussed is that bag and mask ventilation is absolutely contraindicated. Why? Already I told you the biggest disadvantage of mask ventilation is that air can leak into esophagus, increase intragastric pressure, increase the risk of aspiration. So bag and mask ventilation is absolutely contraindicated. And second thing is that as soon as the patient fall asleep, assistant apply cricoid pressure, which is called as Salix maneuver. Salix maneuver. So what the assistant is doing by applying cricoid pressure, he or she is pushing the cricoid posteriorly to compress esophagus between his fingers and vertebral column. So esophagus gets compressed, so patient will not be able to aspirate. CNS complications can be convulsions. So what are the causes of convulsions? Hypoxia, IV agents, methoxytone, and that's why methoxytone was used for ICT. Propofol, etomidate, they don't produce GTCS but can produce myoclonic activity. Enflurane and sevoflurane are the two inhalational agents. Actually, enflurane is obsolete because it was epileptogenic. And then convulsions can also occur in local anesthetic toxicity. GI, the most common complication is nausea and vomiting. And nausea vomiting is not the most common GI complication. In fact, nausea vomiting is the most common post-operative complication of general anesthesia. And why I'm using green pen? Because the previous auditing report has shown pain to be the most common post-op complication. But recent evidence has shown nausea vomiting to be the most common post-op complication. Anaphylaxis. Now, as per the recent auditing report, which is a British study, the most common cause of anaphylaxis is antibiotics. Very important. Because previously, the French studies had shown the most common cause of anaphylaxis in perioperative period is muscle relaxants. But now it is proven antibiotics are more common cause of anaphylaxis. Then thermal complications can be malignant hyperthermia. And what are the causative agents? Suxamethonium, already I told you, is the most commonly implicated drug to trigger malignant hyperthermia. Suxamethonium. Then all volatile agents, they can also trigger malignant hyperthermia, but the maximally it is seen with halothane. So if they ask you most commonly implicated volatile agent, then it is halothane. But if they ask you most commonly implicated agent, then it is suxamethonium. So both way it has been asked. Management, we all know dantrolene sodium is the drug of choice. And dantrolene sodium, you know, directly at sarcoplasmic reticulum block the release of calcium, because in malignant hyperthermia, excessive release from sarcoplasmic reticulum is responsible for excessive muscle contraction, which produces a heat which causes hyperthermia. So dantrolene sodium can directly act at sarcoplasmic reticulum level to block the release of calcium. Then, if a patient is susceptible, then what should be the anesthetic management? IV agents, all we can use, but propofol is protective actually. Propofol can delay or even prevent malignant hyperthermia. Then problem is maintenance. Maintenance, we have seen we are using volatile agents. So we cannot use volatile agent. So anesthesia in these patients will be maintained with opioids rather than on inhalational agents. Now, position related complication. The most common problem of different positions is that in different positions, nerve can get compressed and entrapped, leading to peripheral neuropathy. Now, as per the latest auditing report, the most common peripheral neuropathy is ulnar nerve. So the most commonly injured nerve during different positions during GA is ulnar nerve. Why green pen? Because previous studies used to say brachial plexus to be most commonly involved, but now ulnar nerve. Then venous embolism, again a very commonly asked topic, in fact very important from your MCQ point of view. So this venous embolism occur in sitting position, and which surgeries are done in sitting position? Posterior fossa craniotomy. So when they open the cranium, dural sinuses get opened, and since dural sinuses are above the level of the heart, so due to negative pressure they will suck the air, leading to venous air embolism. And the most sensitive test to detect venous embolism is transesophageal echocardiography, and it is so sensitive that it can detect as low as 0.2 ml of air. So very sensitive. Then local anesthetics are used to give the regional block. Now the sequence of nerve block, they say it most controversial, but actually it is not. I will tell you, because you know that nerve blocks may be peripheral nerve blocks or nerve blocks, peripheral nerve blocks or central axial block. Central axial blocks mean given along the central neuraxis, that is spinal and epidural. So for any block given along the spine is central axial block. So for central axial block, the sequence is first to be blocked is B fibers, then A and then C. However, for peripheral nerve blocks, first to be blocked is A, then B and then C. The problem comes is they don't mention. They will simply say most peripheral nerve block and the most sensitive fibers will be A, followed by B and C. But if they specifically give spinal and epidural, then the most sensitive fibers are B followed by A and C. And the recovery is in reverse order. Fine. So this is the reason why you will see controversy related to this. Now, toxicity, local anesthetic toxicity, you know, CNS is involved at much, much lower doses as compared to CVS. That's why maybe the first presentation of the patient may be convulsions. Now, local anesthetic with adrenaline, you know, it is absolutely contraindicated for ring block of finger, toes, penis, and pinna because these structure have end arteries, and adrenaline with local anesthetic can cause gangrene of these structures. Regarding individual agents, Prilocaine, the most important thing about prilocaine, which you have to remember, is methemoglobinemia. Although methemoglobinemia, other than prilocaine, is also caused by benzocaine, but mainly it is caused by prilocaine, but benzocaine also causes. Lignocaine, also called as lidocaine and available in the brand name xylocaine. So this you can say is the most commonly used local anesthetic. So you have to know the duration, then only you will be able to know whether you will be able to perform this surgery under lignocaine or not. So duration without adrenaline is just 45 to 60 minutes, less than 1 hour. However, when you add adrenaline, systemic absorption is reduced, more drug is available at local site to act, increasing the duration to 2 to 3 hours. And what is the concentration of adrenaline that is used with local anesthetic? 1 in 200,000. 200,000 means 1 in 2 lakhs. Although in pharma book, it is given 1 in 1 lakh, but that's not correct. 1 in 2 lakh. Then second thing you have to know is the maximum safe doses. Because if you know the maximum safe doses, then only you can prevent toxicity. So the maximum served dose without adrenaline is 4.5 milligram per kg. But when we use adrenaline, systemic absorption is reduced. So our safety margin increases. And instead of 4.5 milligram, we can easily give 7 milligram per kg. So without adrenaline, 4.5 milligram per kg. With adrenaline, 7 milligram per kg. Bupivacaine, again, a very, very commonly used local anesthetics. In fact, if you ask me in anesthesia, bupivacaine is more commonly used than lignocaine. Duration of action of bupivacaine is 2 to 3 hours, and maximum safe dose is 2 milligram per kg. 2 milligram per kg. Bupivacaine is excellent for painless labor or post-op analgesia. Very commonly, used for painless labor and post-op analgesia. Why? Because at low concentration, it produces only sensory block. So this is a unique feature that at low concentration, it produces only sensory block, making it as an excellent agent for painless labor or a post-operative analgesia. Then a very important thing about you can say lignocaine is bupivacaine is cardiotoxicity, because it can manifest in any form, ranging from any kind of bradyarrhythmia to any kind of tachyarrhythmia. And ventricular tachycardia is not so infrequent with bupivacaine. Lignocaine, you all know, is used for the treatment of ventricular tachycardia, while bupivacaine itself can cause ventricular tachycardia, and nowadays the drug of choice for ventricular tachycardia induced by bupivacaine is amiodarone. And why green pen? Because previously we were preferring bretylium, but now bretylium, it has been seen that amiodarone is better than bretylium. And you have to give antidote whenever there is toxicity, and antidote for bupivacaine toxicity is intralipid. So what does intralipid do? Obviously, it block the bupivacaine. Then two isomers of bupivacaine are levobupivacaine and ropivacaine, which are S isomers of bupivacaine. And the major advantage of this S isomers is that they are less cardiotoxic. So that is why actually they are preferred. In fact, the least is ropivacaine. So lopivacaine even should be preferred over levobupivacaine. So I can say among these three, ropivacaine is least cardiotoxic. So ropivacaine, if not available, levobupivacaine, if not available, then bupivacaine. Peripheral nerve blocks, I told you regional anesthesia can be peripheral nerve blocks or central axial blocks. Among peripheral nerve blocks, most commonly uses brachial plexus block, which is used for upper limb surgeries. And brachial plexus, although can be given at four sites, interscalene, supraclavicular, infraclavicular, axillary level, but the most commonly used approach is supraclavicular. However, you have to be very careful, because one of the most bothersome complication of supraclavicular approach is pneumothorax, particularly supraclavicular means above the level of clavicle, particularly if your needle is medial. Then you know that the dome of pleura comes like that and you can puncture. So keep your direction always lateral. Then stellate ganglion block is not that commonly given as commonly asked in your MCQs. Stellate ganglion block carries the sympathetic supply of the upper limb. So obviously is used for reflex sympathetic dystrophies. And reflex sympathetic dystrophy, you know, is a group of diseases which happens because of the sympathetic overactivity. So must be treated by a sympathetic block, that is the stellate ganglion block. The site to give stellate ganglion block is the Shagnac tubercle, which is the tubercle of the transverse process of C6. So just at the level of cricoid, you go laterally till the border of anterior sternocleidomastoid, and then you go down perpendicular to hit the tubercle of the transverse process of C6, that is Shagnac tubercle. How you know your block is successful? Patient must exhibit all signs of Horner syndrome that you all know: ptosis, meiosis, anhidrosis, or anophthalmos. Central axial blocks means spinal and epidural. So very important is you have to know the extension of the spinal cord. In infants, spinal cord extends up to the lower border of L3, but in adults, the growth of vertebral column is more, so it extends up to the lower border of L1. This is important because in infants, if you are doing lumbar puncture, you should not use even L3-4 space, anything below L3-4, because it is up to the lower border of L3. If your needle become capillate, you can cause direct injury to spinal cord. Then structures which are encountered when you are going posterior to anterior, first to be encountered is skin, then is the subcutaneous tissue, then is the supraspinous ligament, which connect the tip of spinous processes, then interspinous ligament, which connect the spinous processes, then is the ligamentum flavum, which is also called as yellow ligament of the body, and then is the dura, and almost adhered to the dura is arachnoid. So dura and arachnoid are adhered. So as soon as you pierce the dura, you also automatically pierce the arachnoid, and CSF is present in subarachnoid space where you give spinal. Drugs, lignocaine used to be used 5%, but it is not used because lignocaine caused cauda syndrome. So that's why lignocaine is not used. So what you are using is bupivacaine, 0.5%, but it is hyperbaric. Hyperbaric means specific gravity is more than that of CSF. So drug will always try to settle down, and it is made hyperbaric by addition of dextrose. Systemic effects. The most common side effect of spinal is hypotension. And why? Because sympathetic block lead to venodilatation, decrease venous return, decreasing cardiac output, leading to hypotension. Most common. So you can say it is the most common uh, complication of spinal anesthesia. So hypotension is the most common complication seen in almost all patients. Then there can be bradycardia. Sympathetic block will lead to parasympathetic overdominance that can cause bradycardia. If spinal become too high, it can cause high spinal. Say if it becomes high enough to block phrenic nerve above C3, then it can cause even apnea or total spinal when it reaches brain. So that can even lead to collapse of the patient. Post-operative, nowadays, actually, the incidence of post-spinal headache has been so drastically reduced that you can say that in current day scenario, the most common post-op complication is urinary retention. Most common post-operative is urinary retention. Most common, I told you, is hypotension. So if they ask you most common complication of spinal, it is hypotension. But if they ask you most common post-op, then it is urinary retention. And why I'm using green pen? Because in books you will find the most common post-op complication mentioned is uh, post-spinal headache, which used to be, but not now. Post-spinal headache, why there occur post-spinal headache, also called as post-dural puncture headache, PDPH. This headache occur because of the puncture in the dura. So you have made a hole in dura. Through that hole, there will be continuous seepage of CSF. So decrease in CF will decrease the ICT. That will lead to shrinkage of brain and meninges, leading to stretching of vessels also. So this headache can be defined as low pressure and meningovascular headache. Single most important preventive measure is cause least damage to the dural fibers, means use very fine gauge spine needles, and dura separating, which are just pencil tip point, should be preferred, or of course dura cutting needles. Epidural. Epidural, we place actually catheter in epidural space. So therefore, epidural is mainly used for post-op analgesia or painless labor, and the needle used is 2OS. And how you differentiate spinal and epidural needle? You can look at the markings. If markings are there, that indicate that it is a epidural needle, and it will be thicker as compared to spinal needle. Technique, there are a lot of techniques which are mentioned, but the most commonly used is loss of resistance. Means as soon as you pierce the ligamentum flavum, there will be sudden loss of resistance, which you can easily make. Now, what are the contraindications for central axle block? Again, important. So what I'm going to discuss is only absolute relative. There may be more than 25, 30. Raised ICT. You just can't think of, because in raised ICT, if sudden loss of CSF occurs, that can cause coning, and medullary coning can cause immediate death of the patient. Coagulopathies or anticoagulants. Why? Because these patients, if they occur traumatic spinal, they keep on bleeding, and this bleeding can accumulate, form hematoma, which can compress spinal cord to cause paraplegia. Patient refusal. If patient is refusing, you cannot give by force. Severe hypovolemia. Severe hypovolemia, because hypotension is the most common side effect. So patient is already hypovolemic, you cannot give. Infection at local site, you cannot introduce infection from outside to cause meningitis. Fixed cardiac output lesions like aortic stenosis or mitral stenosis, they have fixed cardiac output, so they cannot increase their cardiac output, so you cannot treat hypotension. So we cannot give spinal. Specialty management, disease management, ischemic heart disease. So if a patient has MI, we have to defer elective surgery. Otherwise, the chances of re-MI are very, very high. If you do surgery, elective surgery within first month, the chances of re-MI can be more than 30 to 40%. So we have to defer elective surgery. How much deferral we have to do, that depends on the way ischemic disease is managed. If it is managed conservatively, then we have to defer elective surgery for 2 months. And why I'm using green pen? Because previous recommendation was 6 weeks. With bare metal, we have to defer for 4 weeks. And why again green pen? Because previous deferral time was 6 weeks. But nobody is using bare metal. Nowadays, they're using drug-eluted stents. So with drug-eluted stents, we have to defer for 6 months. Now, why again green pen? Because previously stents used to undergo epithelialization in 1 year. So we have to continue dual antiplatelet for 2 years. And on patient in clopidogrel, we cannot take the patient for surgery. But new stent, they undergo epithelialization in 6 months. So we can consider the patient after 6 months. Then if the patient is was managed by bypass surgery, then 6 weeks. Previous recommendation was 6 weeks. Current is also 6 weeks. So how to manage a cardiac patient? You can give regional or GA depending on the requirement. If you are giving GA to a cardiac patient, what are the agents what you have to choose? Induction will be done with etomidate, most cardiac stable. Maintenance with isoflurane, I told you minimum decrease in cardiac output. And the muscle accent which you are going to choose is vicuronium because that is most cardiac stable. Respiratory system, we always prefer regional. Of course, why we'll be touching the respiratory system when we can get a surgery done under regional anesthesia? So regional. Induction, propofol is a good bronchodilator. So we prefer propofol, and respiratory system mainly, you can say mainly is asthma or COPD. It's a good bronchodilator, so we prefer. However, uh, for controlled patient, propofol. However, for active asthma, we have to use a very potent bronchodilator, that is ketamine, I told you. Otherwise, for a normal asthma patient, normal COPD patient, propofol is good enough. Maintenance sevoflurane, I told you, maximum bronchodilation. And muscle action, generally we prefer steroidal kind because benzyl isoquinones type, they can cause bronchospasm by releasing histamine. Hepatic patient, anesthesia of choice is GA because of the associated coagulopathies, we avoid regional. Induction with propofol, of course, for hepatic patient, we'll prefer agent with a short half-life, propofol a short life. So propofol. Maintenance, sevoflurane, I told you, minimum decrease in hepatic blood flow. Muscle laxant, cisatracurium, and if not available, then atracurium because metabolized by Hoffman degradation, so not dependent on liver. Renal patients, we cannot give fluid. When you cannot give fluid, you cannot treat hypotension, so you cannot give spinal. So anesthesia of choice is GA. For GA, again, shorter half-life, that is propofol. Maintenance, desflurane, because no fluoride, I told you, least metabolism. Muscle accent, no risk of accumulation. Of course, cisatracurium or tracurium. Neuromuscular disease or muscular dystrophies patient, these patients, they exhibit abnormal sensitivity to muscle accent. So aim should be to avoid muscle accent. Avoiding muscle accent means avoiding GA. So anesthesia of choice is regional. Regional. But if you are giving GA also is not possible under GA, the most important thing we have to take care is we have to use safe muscle accent. And safe muscle accent are muscle accent which are short acting and which does not have any risk of accumulation. Mivacurium, short acting, no risk of accumulation, metabolized by pseudocholinesterase. Cisatracurium, atracurium, also no risk of accumulation because they are also metabolized by Hoffman degradation. Succinylcholine is absolutely contraindicated for muscular dystrophy patients. In fact, giving succinylcholine to muscular dystrophy patient means almost inviting the death of the patients. The patients are so hypersensitive that serum potassium can rise to or neurosurgical anesthesia. Induction agent of choice is thiopentone. Why? I told you, because it is cerebroprotective and it is anticonvulsant. Maintenance, sevoflurane. Why? Because it minimally increases the intracranial pressure. Muscle accent, non-depolarizers are coordinate compound, do not cross the blood-brain barrier. So all non-depolarizers are safe. Succinylcholine should be avoided. Why? Because I told you succinylcholine increases all pressures, intraocular, intragastric or intracranial pressure. Obstetric patients are the most common group coming for surgery. So they come to us either for cesarean or for painless labor. For cesarean, anesthesia of choice is spinal. Avoid GA. Why? Because of the increased chance of aspiration. A pregnant patient is 4 to 8 times at increased risk of aspiration. And why you all know, because their LES is totally incompetent. So even if you are giving GA to a pregnant patient, it should be rapid sequence induction irrespective of the fasting. So pregnant patient, even if she is fasting for 8 hours, we have to consider a full stomach and we'll give GA with rapid sequence induction. Then another important thing, as per the latest study, the vasopressor of choice is phenylephrine. This question came in INICET, and that 3-4 years back, I think. At that time, ephedrine was the vasopressor of choice, but now it has been proven that phenylephrine causes less vasoconstriction in placental circulation, so it is preferred over ephedrine. So again, important from recent advancement point of view. Another important change for PI, that's why I'm using green pen. Nowadays, for PIH patients also, the anesthesia of choice is spinal. Previously in books, you will find it is given epidural, but actually off-label, we were giving spinal, but now it is official that for PIH patients, you can safely give spinal. Second group, I told you, patient coming for painless labor. Uh, The most preferred technique is lumbar epidural. We will place a catheter in epidural space we give continuous infusion of the drug. If lumbar epidural not possible, the alternative may be Entonox, which is 50% oxygen and 50% nitrous oxide. Pediatric. For pediatric patient, we can give regional, but even to give regional, we have to give G. And induction pediatric, again, very commonly asked questions. Trickily, I told you, first method is IV propofol. So don't get tricked by the question. First method will always be IV. If IV not available, then the second choice will be inhalational. And in inhalational, the first choice is sevoflurane, smoothest induction. If sevo not available, second and last choice is halothane. Isoflurane and desflurane, they cannot be used for induction because they have got irritating induction. Daycare surgery. So if you are giving a daycare surgery patient anesthesia, the drug which you have to choose is IV agent of choice will be propofol. Opioid which you are going to choose is remifentanil because remifentanil is also metabolized by esterases, RBC esterases. Inhalational agent of choice is sevoflurane. In spite of having little delayed recovery, the delayed recovery difference is 1 to 2 minutes, and side effects of desflurane is irritating induction. Cost is very expensive, more environmental hazard. So because of all these reasons, sevoflurane is preferred over desflurane. Muscle accent, already I told you, is mivacurium, metabolized by pseudocholinesterase, and benzodiazepine of choice for daycare surgery is midazolam because it also has shorter duration of action. Complication. The most common complication is drowsiness, which is seen in almost 50 to 53% of the patient, but this drowsiness is mild drowsiness. However, sometimes we are not able to discharge the patient on time. So the reason for this delayed discharge or overnight stay or readmission after discharge is surgical causes. Mainly it is bleeding. Mainly it is bleeding. Anesthesia for laparoscopy, very commonly used. The most preferred gas for laparoscopy is carbon dioxide. Why? Because it has got very high diffusibility. High diffusibility. However, carbon dioxide has its own complications. So therefore, they say ideal gas is argon. Argon because it is inert. Very important thing is why complications of laparoscopy happens if it is excessive intra-abdominal pressure, which can compress IVC, decreasing cardiac output, leading to severe hypotension. So all these complications can be avoided if you ensure that during surgery, intra-abdominal pressure is maintained between 12 to 14 mmHg. Never allow this intra-abdominal pressure to go above 14 mmHg. Critical care and oxygen delivery devices, one of the very important. In last 5 years, you won't find any exam where you will not find question on oxygen delivery devices. So simple oxygen delivery devices includes nasal cannula. This is nasal cannula. This is simple oxygen mask. which is also called, oxygen mask. This which is also called as Hudson mask or MC mask, that is McCartney mask. So this is simple nasal cannula, and this is oxygen mask with reservoir. You can see there is a reservoir bag, which is again of a rebreather type and non-rebreather type. So sometimes they give rebreather oxygen mask means, or non-rebreather oxygen means mask means they are simply talking about oxygen mask with reservoir. And this is a Venturi mask, which is available in different colors. Now, the most important thing which you have to know is the maximum oxygen and flows. Very commonly asked. For nasal cannula, the maximum flow is 6 liter, and at 6 liter, the maximum output is 0.45, or you can say 45%. With simple oxygen mask, that is McCartney mask or Hudson mask, maximum flow that you can use is 10 liter, and it's 10 liter, the maximum output means maximum inspired oxygen is 0.6, or you can say 60%. Oxygen mask with reservoir, maximum flow that you can use is 15 liter. And this flow, the maximum output they say is 0.8 to 0.9, or you can say 80 to 90%. Venturi mask, maximum flow is 15 liter. And at this maximum output is again 0.6, and that is 60%. However, this 60% is fixed. While with these agents, this output can variable with the changes in the patient respiratory parameters. So Venturi mask, whatever you are giving, that is fixed. Then one more device which become very popular during COVID is high flow nasal cannula. As the name suggests, high flow means we are very high flow. High flow means you can give 50 to 60 liter per minute, but they should be humidified. And they are automatically humidified. You can see there is active humidifier. You cannot give such high flow without humidification. That can completely damage the cilia. And it can provide some degree of positive and expiratory pressure. See, when you are giving such high flow obviously is going to provide some positive pressure in alveoli. That means positive and expiratory pressure. So that will prevent alveoli to become collapsed. And theoretically, not only theoretically, in fact, indirectly, it can decrease the dead space by washing carbon dioxide from airways. All of the airways are filled with oxygen. So indirectly, you have removed the carbon dioxide, so decreasing the dead space. Non-invasive ventilation, very commonly used, and non-invasive means given through mask. So what are the most common indication is, type 2 respiratory failure, that is COPD, and obstructive sleep apnea. So these two are the most common indication for applying non-invasive ventilation. Major advantage, and there is decrease chances of ventilator associated pneumonia, VAP. VAP occur due to intubation, which can be reduced. Disadvantage, with this mask, patient become claustrophobic and there is increased chances of aspiration. We are giving positive pressure with mask, so there is increased chances of aspiration. Now, the most important thing from ventilation point of view, if you'll ask me, lung protective strategy, because it is not the your you can say type of ventilator, mode of ventilation, which define morbidity and mortality. Morbidity and mortality depends whether you are ventilating the patient with lung protective strategy or not. And the major aim of lung protective strategy is to protect the lung against barotrauma. So what all you can do? Use low tidal volume. Low tidal volume means 4 to 6 ml per kg of the idle body weight. Continuously monitor plateau pressure. Plateau pressure is the pressure at alveolar level, and barotrauma happens at alveolar level. So continuously monitor plateau pressure and ensure it remains less than 30 centimeter water. Keep positive and expiratory pressure. We are giving positive and expiratory pressure to keep alveoli open during expiration, but you are keeping alveoli even open during expiration, so that increase the chances of barotrauma. So they say start with the minimum PEEP, which is 5, and then titrate. Then another thing, we have to protect the lung against hyperoxia. because oxygen toxicity can cause irreversible brain damage. So ensure that FiO2 remains less than 0.6. CPR or CPCR. CPCR is done for cardiac arrest, and you know it is done under four headings: basic life support, which can be provided at any place; ACLS, advanced cardiac life support; post cardiac arrest care, which is required once the patient is revived; and recovery, they have also added that patient should be fully recovered before being discharged. So, what is the basic difference between BLS and ACLS? Whether you are doing CPR under BLS or ACLS, you are managing airway, breathing, circulation, and defibrillation. In BLS, airway is managed manually, with ACLS with equipment. Breathing in BLS by mouth to mouth or bag and mask, anything beyond bag and mask. It can be laryngeal mask airway, it can be endotracheal tube, it can be tracheostomy. And circulation is in both is managed by cardiac muscle. Defibrillation with AED, that is automatic external defibrillator, is part of basic life support, while manual defibrillator is a part of advanced life support. AED are automatic, means you have to just switch them on and put the pads over the patient chest. They will automatically diagnose the rhythm, and if the rhythm is shockable, they will automatically give the shock. And this AED are used for public. So they are actually are also called as PAD, that is public access defibrillator. Manual defibrillators, the one which we are using in hospital, we have to charge them, we have to select the energy, and we have to give shock. So they can be only used by medical personnel. So they are the part of advanced life support. Drugs obviously can be given only in hospital setup. So they are the part of advanced cardiac life support. So it is airway, breathing, and circulation. Circulation means cardiac massage. So let's see important features of cardiac massage. Although this infants and children is part of PCLS covered in pediatric, but just for comparison point of view, I have added them. Pulse check in infants is brachial, while in adults and children it is carotid. Compression area in pediatric patient is mid sternum, while in adults it is lower third of sternum. Compression in infants is done with 2 to 3 fingers like this, while in children it is done with heel of one hand, and in adults, both hands, one hand locked over the other. Depth 1.5 inch. Uh, in infants, advanced airway. Without advanced airway means you are ventilating the patient with bag and mask. With advanced airway means you have intubated. Now it also depends. Now without advanced airway, it depends whether you are a single rescuer or one rescuer. If you are a single rescuer, then you can say ratio is 30 is to 2 for all ages. But if you are two rescuers, then this ratio becomes 15 is to 2 for infants and children and 30 is to 2 for adults. However, once you have intubated the patient, there are no ratios. One person will continue compression at a rate of 100 compressions per minute, and second person will continue ventilation at a rate of 20 to 30 per minute in infants and children, as per the 2020 guidelines, while 10 per minute in adults. And there is no synchronization between these two people. One person will continue compression at a rate of 100 to 120. Second person by watch will give 10 breaths in an adult per minute, and in infants and children it will be 20 to 30 breaths per minute. So in 2020, what are the changes which they have made? Recovery, I told you, is now the fourth chain of survival. Then in pediatric CPR, the most important change which I told you they made is that now the respiratory rate is 20 to 30 per minute, which used to be 10 before, like adults. Then another very important thing they have made new changes: intraosseous route. Intraosseous means into medullary cavity, and it is preferred over endotracheal. Anything can be given. Anything means you can even give blood transfusion through intraosseous route and can be used at any age. Like previously, it was used only for children less than 6 years, but now it can be used at any age. Now let's discuss PYQs. for last 6 years, I try to uh, collect PYQs. So rapidly, let's discuss the PYQs of INICET. Question 1. All are acceptable method of free flow oxygen delivery system except self-inflating bag, mask given close to mouth and nose, reservoir bag with mask given close to mouth and nose, tubing connected with oxygen supply close to mouth and nose, mask is connected to oxygen supply close to mouth. See, what this is what self-inflating bag close to mouth and mouth means. This is ambu bag. And reservoir bag with mask means mask with reservoir. Tubing connected with oxygen supply means it is nasal cannula. And this is simple oxygen mask, mask with oxygen supply close to mouth. So this, they have asked a free flow of oxygen delivery. So these three. And ambu bag is used for ventilation. This is not flow. You have to compress to give ventilation. So A. Which of the following is our second generation LMA? Intubating LMA? No, it is not second generation. It doesn't have inflating, and you can say separate tube for stomach decompression. So no. Procil, yes. Prototype. Flexible LMA? No. Again, it is not second generation. Embu is both first and second generation. So Embu. And I think the same exam, it was last year only. And they have given Embu bag photo in NEET PG, and they've asked whether it is first or second generation, and the photo was of second generation. So only Procil and Embu bag are second generation. Adequate CPR in adult. 30 compression to ventilation, correct. Adequate chest recall, yes. After compression, you have to release, correct. 100 to 120 compression per minute, yes, correct rate. 3 to 4 centimeter, no. 2 inches means 5 centimeter, 5 to 6 centimeter. So this is wrong. So ABC. So they have given in different formulations. So I have just simplified it. Question. Which inhaled anesthetic is used for pediatric induction? Sevoflurane, desflurane, isoflurane, sevoflurane. I told you. Sevoflurane, smoothest. A patient was given rocuronium for short surgery. Which of the following would you use to end it effect fast? Androphonium, neostigmine, sugammadex, glycopyrrolate, sugammadex. Immediate reversal, I told you, of rocuronium. A patient in ICU after waking up from coma was given morphine for pain relief. After morphine, patient developed respiratory depression. Which of the following drug must be given to treat respiratory depression? Naloxone, buprenorphine, naltrexone, bupropion. C, naloxone, correct. Most commonly used. Naltrexone is long acting, can be used. You know that mixed opioid, buprenorphine is mixed opioid. All mixed opioids can reverse the effect of all pure agonist in high doses. High doses, all mixed opioids, they are antagonizing effect. So ABC. High quality CPR consists of allow complete recall, yes. Depth should be 5 to 6 centimeter, yes. Chest compression 100 to 20, yes. Breathing rate at a rate of 20 to 25. No, this is not for adult, this is for pediatric. So 1, 2, 3. C. 15-year-old boy reported to emergency with breathing difficulty. Monitor was attached and following graph was seen of Capnography. What can be the diagnosis? This is shark fin. So of course it is asthma. Asthma, pericarditis, tamponade myocarditis, asthma. A only. D. Minimum platelet required for elective surgery 30, 40, 50, 70, 50,000 is the minimum platelet that we require for elective surgery. Which of the following test is done to see the pregnancy of transpalmar arch? Allen's, Fallon's, Tinel, Durkheim, modified Allen's test. You are an intern posted in OT. You are asked to identify the marked arrow. This is a marked arrow of EtCO2. Okay, 39, and this is a graph. Flow of CO2 during exhalation, which is low. Flow of CO2 during exhalation, which is normal. Flow of CO2 during exhalation, which is high. Flow of CO2 during inhalation, which is normal. 39 is normal. So flow of CO2, which is normal. E. Expiratory, expired, EtCO2. Maximum effort is delivered by non-rebreathing mask, nasal cannula, Hudson mask, Venturi mask, non-rebreathing mask, 80 to 90%. Non-rebreathing, I told you, is oxygen mask with reservoir, can be called as non-rebreather oxygen mask or rebreather oxygen mask. Post-operative pulmonary complications are seen in all of the following. BMI more than 30, yes, more than 30. Obviously, they will have restrictive pulmonary functions because of the extra parenchymal fat. True. Upper abdominal surgery, yes, because of the pain, will not be able to adequately, patient is not able to take adequate ventilation. So correct. Patient with 7 packets of smoking, yes, smoking inhibits cilia. Age 70. Oh, decrease pulmonary reserve. So all of the above. So all, uh, you can say, increase the risk of post-op complications. Regarding CPR, can be given irrespective of fracture? Yes. Adult chest compression and ventilation is 30:2 for two rescuers. For adults, always 30:2 irrespective of rescuers. Compression rate 100 to 120, yes. AED, if available, give compression and shock every 3 minutes. No. See, after giving a shock, we have to continue CPR for 2 minutes because it has been seen that it takes 2 minutes for the heart to generate normal cardiac output. And after giving, uh, then only we check the rhythm. And only if the rhythm you will find shockable, then you are going to give shock. So you can say every 2 minutes, not 3 minutes. For infants, compression ventilation ratio 32 for two rescuers. No, it is 15:2. So A, B, C. Assertion for airway management, flexion of neck is required. Region, jaw thus prevent tongue falling back on postopharyngeal wall. Okay. For airway management, flexion, no. For airway management, we do triple maneuver. So what is triple maneuver? Triple maneuver is chin lift, jaw thrust, and neck extension. Chin lift means when you lift the chin, chin lift and head tilt. Head tilt means neck extension. So it will be extension. So it's not a correct statement. So A is not correct, but B is correct. Jaw thrust means anti-displacement of mandible, and this is done to prevent tongue falling back on posterior pharyngeal wall. So region is correct. So A is false, but R is true. So D. Steps of intubation sequence. Flexion of lower cervical spine, extension at atlantopital joint, inflate cuff, introduce laryngoscope from right side of the mouth, confirm the position of the tube. See, the position for laryngoscopy is extension at atlanto-occipital joint and flexion at cervical spine, and this position you know is called as morning sniffing position. So first you have to position. So first will be A, then you will introduce laryngoscope from right side of the mouth. If a left-handed person, I mean right-handed person, you will hold laryngoscope in left hand and introduce from the right angle of the mouth. So see, and then you intubate, then inflate the cuff of the tube, and then confirm the position of tube. So A, C, B, D. A, C, B, D. D. False statement about the following image. What is this? Automatic external defibrillator. Okay, false. It is the part of advanced life support. No, it is a part of basic life support. It only delivers 300. No. If it is a biphasic, it will deliver 150 to 200. If it is monophasic, it will deliver 360. One pad is applied over precordium and other over sternum. No. One pad is over precordium, other is right infraclavicular. Wrong. It is used for medical personnel only. No, it is for common man. So all of them are false statements. The patient was on epidural for post-op analgesia on a dose of 3 milligram morphine. However, by mistake, one day accidentally 12 milligram morphine was injected through epidural catheter, which statement is not correct. Patient will complain of itching. Yes, itching is one of a prurite is a very common side effect of opioids. Supplement oxygen with mask may be required. Of course, it will be required. Patient will have urinary retention. Yes, urinary retention is one of the major side effects of opioids. True. Patient will complain of numbness. No. So the main advantage of using opioids or local anesthetics is that opioids do not causes motor block. Local anesthetics, Bupivacaine, I told you, low concentration produces only sensory block, but by mistake, if you give high concentration, that can cause motor block. So that issue is not there with opioids. So D. A soldier was brought from Siachen suffering from hypothermia. Which of the following temperature closely reflect core temperature? Oral, rectal, skin by infrared detector, esophagus. most commonly and the best site I told you is esophagus. Match the following anesthetics with respect to their side effect. Okay. Propofol among these, Propofol 1, Propofol among these rigid chest syndrome, pulmonary vasoconstriction, egg allergy, hypotension, diffusion anesthesia, adrenal insufficiency. Consider egg allergy. However, egg allergy is not a contraindication. Patient with egg allergy can safely receive propofol because propofol contains egg lecithin and egg allergy is always from egg white. Fentanyl, rigid chest syndrome, wounded chest syndrome, I told you. So 2 is A. Midazolam, among these, I will choose hypotension, although benzodiazepines causes hypotension only in very high doses, but yes, high doses they can. Nitrous oxide, pulmonary vasoconstriction, yes. So that is why nitrous oxide is actually contraindicated for pulmonary hypertension. It is a pulmonary vasoconstrictor. While nitric oxide, on the other hand, is a pulmonary vasodilator. So 1C, 2A, 3D, 4B. 1C, 2A, 3D, 4B, C. So dissociative anesthesia, ketamine and adrenal sufficiency with etomidate, which is not an obvious advantage of high flow oxygen delivery device, that is high flow nasal cannula. Humidification is auto preserved, yes. Can deliver higher concentration as compared to nasal cannula. Nasal cannula 6 liter. Here you can deliver 60 liter. Decrease in need to intubation as compared to an IV, of course not. Accurate in delivery, yes, they are accurate. So C. They do not decrease the need of intubation as compared to non-invasive ventilation. The patient is undergoing modified radical neck dissection for laryngeal malignancy. While dissecting the vena tributatus, the surgeon elevated the internal jugular vein for ligation. Suddenly, the patient ETCO2 dropped from 30 to 12, and the patient developed hypotension along with cardiac arrhythmia. Which of the following is most likely cause? Sympathetic overactivity, vagal stimulation, venous embolism, carotid body stimulation. C. Venous embolism. See, elevated the jugular vein means above the level of the heart, and they give incision so it can suck the air. And why CO2 decreases in air embolism? Because in air embolism, one of the segment of the lung is blocked. So that is not receiving CO2. So less CO2 means exhaled CO2 will be less. 23, time required for pre-oxygenation before tracheal intubation, 1, 3, 5 to 7, 5 minutes. 3 minutes I told you, to eliminate nitrogen from lungs. Which of the following drug can be used as intravenous induction agent? Bupivacaine, lorazepam, neostigmine, dexmedetomidine. Bupivacaine cannot be given IV. Neostigmine reversal agent. Dexmedetomidine produces sedation. It cannot, even at high doses, cannot produce induction. Lorazepam, benzodiazepines can produce, although they are not never used for this purpose, but they can. A patient who was on ventilator and being ventilated for fast few days suddenly pulled out endotracheal tube. What's the next step of management? Reintubate, oxygenate and reintubate, start CPR, watch for spontaneous breath and reintubate if needed. See, if the patient is automatically pulling the endotracheal tube, you know, in many patients, almost you can say one third of such patients, we can avoid reintubation. So they are conscious enough to remove themselves. So never be in hurry to reintubate, observe them. Give oxygen by mask, observe them. If deteriorate, reintubate, they may automatically extubate by themselves. So this is the most preferred technique. Watch for spontaneous breath and reintubate if required. All are true about the procedure done by this needle. This is spinal needle. All true except breath holding is not necessary. This is a true statement. No need to hold the breath. Coagulation is not an absolute contraindication. No, it is absolute contraindication. Bleeding hematoma can cause paraplegia. Bevel should face medially while inserting the needle, ideally, because see, your dural fibers are longitudinal. So if you keep bevel medial or lateral, you will cause less damage. So theoretically true. Can be done in lateral, yeah, lateral or sitting, depending on your preferences. So B. Coagulation is an absolute contraindication. 100% oxygen is given in to patient after nitroxide anesthesia for second gas effect, diffusion hypoxia, barotrauma, airway collapse. Diffusion hypoxia, which is also called as Fink effect. So what happens when you stop nitrous oxide at the end of surgery? lungs will become empty of nitrous oxide. So the concentration of nitrous oxide is more in blood and tissues. So nitrous oxide from blood and tissue will gush into lungs, replacing oxygen from there, creating a hypoxic state called as diffusion hypoxia. So to prevent this diffusion hypoxia, we have to give 100% oxygen for at least 10 minutes. What is the ratio of cardiac compression and ventilation for all ages done by a single rescuer? 30:1, 30:2, 10:1, 15:2, 30:2. On giving epidural anesthesia, 3% xylocaine with epinephrine. Actually, 3% xylocaine nobody is giving. It should be 2% ideally. Available is only 2%. Injected within 3 minutes, the patient had hypotension, most probable region. Systemic toxicity, drug injected to subarachnoid space, vasovagal attack, anaphylactic shock. This is drug injected into subarachnoid space. So one of the complication of epidural is accidentally you introduce your drug into subarachnoid space. So drug will spread high and patient can develop total spinal and collapse. Systemic toxicity can produce a collapse of the patient, but that is going to occur instantly when you are injecting IV, not after 3 minutes. Vasovagal present, bradycardia, anaphylaxis shock will present like laryngospasm, bronchospasm. Drug which undergoes Hoffman elimination, atracurium, pancurium, vicurium, succinylcholine, of course, atracurium. Allergic reactions occurring during the perioperative period due to administration of local anesthetic, neuromuscular blockers, opioids, antibiotic. Actually, I modified this question. Here, there was some other choice because this question was asked, I think, 4 years back or so, or 3 years back. And that time, the most common cause was muscle relaxants. That was a French study, but I told you recent studies have proven antibiotics. So if the same question comes, I modified this. The choice was not antibiotic. So I've added antibiotics in the question to make it a question of a current day. All of the following act on neuromuscular junction except pipercuronium, dantrolene sodium, succinylcholine, mivacurium. Dantrolene sodium is used for malignant hyperthermia acting at sarcoplasmic retinaculum. All other are muscle relaxants. Pipercurium, mivacurium, non-depolarizer, succinylcholine, depolarizer. Which of the following is true regarding rapid sequence induction? High volume, they was true, okay. High volume, low pressure cuffs are better than low volume, high pressure cuff in preventing aspiration. No, theoretically, no. So I'll give it a false statement. Simultaneous administration of induction and neuromuscular blocking agent, no. First, we have to give induction and then we have to give muscle relaxant. Always pre-oxygenate the patient with 100% oxygen, mandatory. Because we are not ventilating the patient with bag and mask. We are keeping the patient in apnea till the effect of muscle accent come. So we have to pre-oxygenate at any cost. Preferred technique is cardiac arrest patient. Actually, this is also true. This is also true because in cardiac arrest patient, we don't know the fasting status of the patient. We don't know the fasting status. So preferably it should be done by rapid sequence induction. So both C and D are correct. The correct relation of age and MAC requirement are respective correctly in which of the following? Neonate, adult, infant, infant, neonate, adult, neonate, adult, infant, neonate. B. You know, our lifetime maximum alveolar concentration is seen during infancy, peaking at the 6 months. Even a neonate has more MAC than an adult. 35. A snap just before entering the epidural space during epidural anesthesia is due to piercing of which ligament? Supraspinous, posterior ligament, ligamentum flavum, interspinous, ligamentum flavum. And this is the loss of resistance technique. As soon as you pierce the ligamentum flavum, there will be sudden loss of resistance. After correct placement, point A in the image lies at. This is the hole and this is procele at epiglottis at level of cords at thyroid cartilage above esophagus, so that you can pass your suction catheterized tube to enter the esophagus to deflate the stomach. In the given figure of capnography, what is the next best appropriate management? Check for endotracheal tube position, check for connection of anesthesia machine, check for soda lime canister, administer skin muscle relaxant. This is curare notch. So you have to give the muscle relaxant. Muscle relaxant that can be used in a patient with high serum bilirubin 6 mg% and serum creatinine 0.5. Vicuronium, atracurium, pancuronium, cisatracurium. This is hepatic failure and liver failure. So atra or cis, and cis is definitely preferred over atracurium. Which of the following combination can be used for daycare surgery? Ramimidaz, propofol, fentamidaz, thio, morphine, midaz, propofol, morphine, diazepam, ketamine. Or remifentanil, midazole, and propofol. Best combination. Which anesthetic agent can cause pain on IV administration? Thiopentone, propofol, ketamine, midazolam. Propofol is oil-based preparation, so injection is painful in almost all patients. So that is all about. So let me see if you have any. I'm going to this site and let me see if there is any queries or doubts. With anesthetic healing system. So let me see if there is any doubt or query. So just I'm going to the YouTube link. The doubts. Okay, Imanshu asking ophthalmic anesthesia already answered. Okay, Imanshu. How to differentiate between KMS or LMS? So I think Rahil, you would have seen now how to differentiate. We have seen all photos of LMA. This is classical LMA. And they will not ask like that. See, mostly they're asking like that. Classical LMA, this tube is flexible. Flexometally means there is a wire which make the tube to become flexible. Embu LMA, of course, is just green, you can say. Or intubating LMA, you can see tube passing through it. Proseal, there'll be second, you can say there'll be port, so it is a second generation LMA. I gel, it is filled with a gel, so you can easily identify. LMA Supreme, you can say you will have difficulty with Proseal, but there is a proper bite block. And look at the curve. It is curved. While Proseal, you can see is straight. And MU LMA, again, green LMA means it is MU LMA actually. Facts to know say why flexometallic are changed and PVC are put if the patient has to keep on tube in post-op. Okay, you are asking if we are keeping the patient in post-op, why we are changing to flexometallic? No, it's not like that. We can use flexometallic also depending. It's not necessary. We're not changing. Many times we're not changing. So it's not necessary to or not mandatory to change a flexometallic in post-op. We can keep. Who is this Falconetti who is saying it is not live video? Falconetti, please don't spread uh, your wrong information. This is purely a live video, and I don't know where you have seen. You maybe see some other session which may be close to it, but this is a live video, and there is a lot of modifications in this, including recent advancement, including PYQ. So this is some person I think who is spreading wrong news. There are some kind of people are like that. Rahil again says, please explain cardiac massage and how it is contaminated according to risk of infection. See, cardiac massage, I told you, it should be done on the lower part of the sternum with one hand locked over other like that, and pressure is generated through shoulders, never through elbow, means your hand should remain straight. And rate already I told you is 100 to 120, and you should compress fully and release fully. Allow recoil and uh, uh, then rate already I told you 100 to 120, and depth already I told you it should be around 5 to 6 centimeter, 2 to 2.4 inches. And how it is contaminated? See, as such, cardiac massage is not contaminated. The I don't think cardiac massage as such can cause contamination. However, yes, if the patient is coughing out something, then it can be contaminated. Otherwise, cardiac massage as such cannot be contaminating. Anything else, right? Or anyone else want to know? I may be just waiting for 2-3 minutes. If there is no uh, more query, I'll close the session. Okay, Rahil, thank you. Hamza says malignant hyperthermia. So, Hamza, malignant hyperthermia, I told you, malignant hyperthermia is a condition, genetic disease, in which there occur rapid rising temperature due to abnormality in a calcium release receptor that is called as ryanodine receptor. So, abnormality this ryanodine receptor will lead to accumulation of calcium in sarcoplasmic reticulum that lead to sustained muscle contraction that produces heat, and this heat is responsible for hyperthermia. So you will see rapidly rising temperature, and CO2 can also rise very, very high. It can go even 80, 90 or 100 mmHg. And such high muscle contraction can release potassium, which can cause hyperkalemia, which can cause ventricular fibrillation, which is the most common cause of death. Triggering agents, I told you, suxamethonium, most commonly triggering agent. All volatile agents can trigger, but most often it is seen with halothane. And for anesthetic management of such patients, best is get the surgery done in the regional. If regional not possible, then induction with propofol. Propofol can delay or prevent malignant hyperthermia by unknown mechanisms. Maintenance is a issue because for maintenance, I told you, we use volatile agents. We cannot use volatile agent, so we have to use IV opioids. Non-depolarizers can decrease the muscle metabolism. So non-depolarizers not only can be safely used, in fact, they are also protective. Fine. Shiv Kumar sir, how to differentiate FiO2 value of different airways treatments? How to remember, Shiv Kumar? Shiv, unfortunately, there is no mnemonic if you will ask me. Just let me go. There is no mnemonic. See, nasal cannula is the just what you can simply remember is, see, nasal cannula is the most basic equipment, so it output will be least 45%. And 6 liter is the flow maximum which you can use. Simple oxygen mask can give little high flow, so 10 liter, 10 liter, so 0.6, 60%. Oxygen mask with reservoir, 15 liter. Venturi also 15 liter. Output of Venturi is 60%, but that is fixed. While with reservoir, it is around 80 to 90%, you can say. So that's how. I mean, there is no mnemonic to remember this. Okay. How to differentiate Mapleson circuit in image-based question? Okay, I'll tell you. See, if it is a single tube, it is McGill. Adult tube and single tube means no tube passing through the other. It is simply McGill circuit. If you see one tube passing through the other, they will always show you one tube entering the other tube. And this tube is for inspiratory gases. They'll mention also inspiratory. Then it should be considered as veins. There was one circuit, a modification of McGill that was lac, where they put an inner tube, and that inner tube was for expiration. So by chance, if they give you, they don't give because nowadays these circuits are not used. So nowadays you will see a trend of last 5 years. They are asking very less questions on Mapleson circuits. So if they give a inspiratory tube for expiration, then it is lac circuit. They will always mention this. If they give inspiratory tube for inspiration, then it is veins. Pediatric circuit you can only identify by the small size of the tubes. and small size of the bag. Look at the size of the bag here. Look at the size of the bag here. So bag size will be small, tube diameter will be less. Then you can know that this is a pediatric circuit, that is Mapleson F Jackson piece. Okay. Concentration of epinephrine I have and IU were the important to remember in the session. Concentration of adrenaline, okay. See the concentration of adrenaline, if you ask me, I'll just tell you, no problem. Let's go to CPR. Okay. So adrenaline can be given through three routes in the same preference: IV, intraosseous, and intramuscular. Endotracheal. So in the same preference, it is given intravenous, intraosseous, and endotracheal. In the same preference. And the concentration of adrenaline, all these three routes is 1 in 10,000. 10,000 except pediatric endotracheal. Pediatric endotracheal is 1 in 1,000. Otherwise, for pediatric intraosseous and intravenous will be 1 in 10,000. Second adrenaline is used for anaphylaxis. So anaphylaxis we give mostly subcutaneous or intramuscular. So subcutaneous or intramuscular is 1 in 1,000. That is undiluted. Undiluted come is 1 in 1,000. So for anaphylaxis, always subcutaneous or IM 1 in 1,000. But even if they give anaphylaxis and they say we give adrenaline IV, then it will be 1 in 10,000. So actually, in fact, you can say concentration depends on the route. If it is IV, I or ET. CPR, it always be through these three routes. Anaphylaxis, rarely we give IV also, then it will be 1 in 10,000. But if they say subcutaneous or IM, then it is 1,000. Clear? Okay, right? You have to remember, very commonly asked actually. Yeah, Hamza, that is also a way. I mean, if you want to remember, not the highest, if you want to remember, yes, that is also a formula that each liter, and this is only applicable for these variable devices, not for Venturi mask. Each liter increase in oxygen flow increases FiO2 by 21%, by 4%, by 4% above 21%. Normally, without oxygen, we are getting 21%. So each liter increase with each of these variable device, say I'm giving 1 liter, that means patient is receiving 25%, 4% above 21%. 2 liter, it will be 29%. 3 liter, it will be 33%, like that. Fine. Okay, fine. I think let me close the session. If you have any doubt, you can ask me anytime, and if possible, I'll try to put this PPT somewhere where you can see these PPTs also. I don't know what is the way, on Telegram or something, where to put. However, I can just give you my. This is my Telegram link. If you want to have any query later, also you can post this on this. Fine. Okay, then I'm closing the session. My best wishes. Okay, then I'm closing the session.